Later, I request Dr. Maria to talk about SLT as first line, changing paradigms in primary open angle glaucoma.
Thank you very much. Good evening, everyone. Thank you for staying till the end. Okay, so I'm going to talk about SLT, something that sounds very popular nowadays, but it's not actually that new. It was described in the 90s by Latina. It uses a Q-switch double frequency laser, ND-JAK laser, with short pulses of 3 nanoseconds, high intensity 400 microns, and it uses non-destructive energy. So the pulses are shorter than the tissue's relaxation time. And that's the key to see the difference, for example, here between a spot done with ALT and a spot done with SLT. So these shots lead to a collagen shrinkage, which leads to stretching of the tissue around the spots, and it leads to a wide access to the Slem's canal. This also at the same time regulates the cytokines and inflammatory markers, and it produces a remodelation of the trabecular meshwork that increases the outflow. And it uses less energy than the ALT. So here in these pictures, you can see the difference in terms of tissue destruction. The picture in the left is done with ALT. The picture on the right is done with SLT. What are the indications? Well, basically open-angle glaucoma. Also, we can use it in ocular hypertension, pseudoexfoliative glaucoma. However, the response is not as good as in a primary open-angle glaucoma. We can use it also in pigmentary glaucoma. And, well, I was surprised with a couple of studies that showed that it's also successful in NTG, in normal tension glaucoma. But it is true that in cases with very, very low pressure, it works less than in those NTG with a higher baseline pressure. In those cases, the success rate is higher. It is absolutely contraindicated in narrow angles, neovascular glaucoma, inflammatory and traumatic glaucoma. About the technique, well, you all know this. We use topical anesthetic drops, pilocarpine. Not everyone uses pilocarpine first, but I personally like it. We can use the Latina lens or the Goldman laser lens. And before, it was very popular to do only 2 sessions of 180 degrees, no? But several studies show that the success rate is better when we do 360 degrees at the same time. We deliver about 100 spots with an energy of 0.4, 1.2 millijoules. If the trabecular meshwork is less pigmented, we need higher energy and vice versa. And typically, we check the eye pressure 1 hour after the procedure. Sometimes we see these champagne bubbles that make us extremely happy when we see them because we know that we are shooting in the proper place. But actually, the success rate is not related to the appearance of these champagne bubbles. The post-procedure treatment, well, we can use a short pulse of steroids or NSAIDs. Actually, the SALT trial showed that the success rate it was better with the use of NSAIDs versus steroids. Artificial tears to reduce the discomfort and stop the hypotensive drugs. In my personal practice, I stop it if the IOP is lower, the baseline IOP is lower than the 30s, no? We prescribe alpha agonists sometimes to prevent the IOP spike after the procedure. We usually check the eye pressure on week 1, 3rd, and 6th. The durability of the laser has been described to be between 2 and 5 years, but I have to confess I have a case that it's working for 10 years already, but well, we never know. No? It's kind of unpredictable. And we have to express this. We have to tell this to the patient. We don't know how long it's going to take the response. And regarding the efficacy, we can expect a reduction in the IOP about at 20-30%. What are the complications? Well, we can find uveitis and IOP spikes. These are the 2 more common complications, and actually it is recommended that we see a severe case of uveitis or a severe IOP spike in the first eye is better to avoid it in the fellow eye. But usually we are doing this procedure bilaterally, so sometimes we don't have the chance to avoid it in the fellow eye. And the rate of serious complications is quite low. When SLT became very popular was when the light trial arose. They basically followed 524 patients for 6 years with open-angle glaucoma or ocular hypertension, and they randomized these patients to drops or SLT. They repeated the SLT maximum 3 times in 3 years, and they showed that the progression rate was lower in the SLT group They required less straps and also less cataract surgery. The quality of life was better, and the time that the patient remained with the target IOP was longer in the SLT group. At the same time, it's cost effective. Other studies, like these ones from Spain, showed the same results, a reduction that was higher in terms of the eye pressure, not significantly higher, but than in the group with treated with prostaglandin analogs. But the safety profile, the adherence, duration, and the cost was better in the SLT group. So it became the first line in the NICE guidelines, in the European guidelines, also in the American Academy. And what about the repeatability? Well, we can repeat it, and in the second time that we do an SLT, we can expect a reduction of 50% in the efficacy. When we do it for the third time, it still can be effective, but the success rate will be a little lower. And the time doesn't matter. Several studies show that it doesn't matter if we do SLT and repeat it after 6 months or if we repeat it after 3 years. Doesn't matter in terms of efficacy. So since it became very popular and it's become the first line of treatment, there are some other techniques that are emerging, like direct SLT. As you can see in the picture, the main difference is that we don't have to use the lens. We don't have to use contact with the patient. We just need to apply the speculum in the eye, and it delivers higher energy to the eye, but the amount of energy that is transmitted to the tissue is actually lower. So we can see the first studies that shows the results from direct SLT. It caught my attention that in this study, they also took a group with primary angle closure glaucoma. And even though the result was not so good like in the primary open angle glaucoma, but it also worked. Well, I would like to know more details about the study, but of course, after treating the primary episode. And we got the first study that is comparing the direct SLT with the regular SLT, done from a similar group from the LIGHT study trial. And they basically, they couldn't achieve the significance to show the non-inferiority compared to SLT, but they found that the results were actually very good. The safety profiles were very similar, and they only found a slight punctate subconjunctival hemorrhage, what was slightly more frequent in the group with direct SLT. But as you can see, at 6 months, at 12 months, the IOP reduction was slightly higher in the SLT group, but of course we all know that patients don't like to do the treatment with the lens, with the gel. It's quite uncomfortable. So, well, what are the take-home messages? That SLT is a safe and efficient treatment for open-angle glaucoma. The IOP reduction in the SLT is higher and more sustained than with monotherapy. It can be repeated with acceptable success rate up to 3 times. It became the first line of treatment in open-angle glaucoma, and these new emergent techniques like direct SLT are showing better results, well, good results, not better, but with similar safety profiles. So let's wait for more studies about this. Thank you so much. Before I forget, I know the questions will be at the end, but I don't have any experience with direct SLT. I would like to know if any of you have any experience with this. Only you have? Yeah, great. Mhm.
Thank you. About the results, so it depends. It's, as I said, in case of SLT, if we use it in patients who have not received any drops, of course, the result is more in naive patients.
Mhm.
Yes, and technique also is very easy.
Great. Thank you so much.
Yeah, okay. Just one question.
So this is Belkin Laser. So this is Israel company who created, but after, so during a few months, Alcon already buys this machine, the SLT machine, and now Alcon distributed. So after that, so they add as a new trial, additional trial, when they try to compare the cornea complications. So at that stage, they didn't find any changes on the cornea. So that's why we don't. they did not compare these results. They just compared complications after DSLT because it has been applied on the also on the cornea part. So that's why only information about it. It's no complication. So during the trial, so mainly they use fixed type. So there is a two type of machine, which is the primary one, which does not have any tracking system or other such abilities. And the new one, this is the advanced type. It's already determined inside, and during clinical trials, the sponsor already, based on the patient's parameter, let's say the trabecular meshwork, pigmentation, and other parameters, apply by themselves. Yes, we don't have currently this device in our clinic, and by our own, we have not decided what to use.
Well, thank you for your inputs. One question to you and then to the panel. Have you tried using SLT in patients who have had a failed TRAB, or you're not getting the desired intraocular pressure? So have you tried using SLT and you've found
Well, I
any
tried.
experience with that?
I don't have many cases like that, but we all have patients who underwent glaucoma surgery. If it fails and they get scared of doing a second surgery and you find yourself with drops again, of course they did the surgery, they don't want to use drops. So that's one of the chances that you have. Of course, after checking that the iridectomy is free, that's not the problem, that you don't have to focus on that place. Yes, I tried and I got that reduction, but I have to say that it was not very sustained. But I have only... that I remember now 2 cases like that, not more. So it's not enough to give reliable results. I don't know if any of you have the same experience.
The light study showed that after 6 years, 70% of people, they were medication free, and almost around 30%, they showed, not 30, 70%, they progressed less compared with the eye drops groups. Is that what you found in your clinical practice? Does it match?
Unfortunately, I cannot follow my patients that long. No, sometimes we lose the track and we are not able to monitor the results like that. No, well, I'm very happy with SLT. And the only problem I had once, it didn't happen to me. It happened in my clinic and the patient ended up with me, but it can happen to any of us. It was that a patient had an IOP spike and ended in filtering surgery. So at that time I got scared and,
Yes.
and stopped doing SLT for some time. But my experience with SLT is similar to a prostaglandin analog. If the eye pressure is higher, the results are sustained, I will say like 3-5 years usually.
Yeah, the reason why I'm asking actually, because I appreciate that the light study is like randomized controlled study and everything, and it's a big, big study. But a lot of my colleagues, we discussed about the SLT in the UK, in Qatar, outside, it doesn't match really. What we are finding in real life, it's a bit more optimistic. The light study is showing possibly more optimistic results.
Yeah.
This is my feeling. I don't know.
Yeah. Many people think the same. But to be honest, I cannot compare with my own data. I wish I could follow these patients longer and more seriously. But yeah, it would be interesting to repeat it.
What is your experience with patients with pseudophakia and SLT? Do you perform it, and do you see any efficacy? Because from my practice, it's not so effective, and we don't like to take this kind of patients.
I used to do it in the past. The response that I was finding in pseudophakic patients was slightly lower. But it's been a long time that I'm not doing it, because if I have a patient with glaucoma and I'm going to do glaucoma surgery, cataract surgery, I usually add a mixed technique. So from long time, I am not doing SLT in pseudophakic patients. I didn't have the chance. But when I was doing it in the past, I have the feeling that the response was slightly lower. I didn't have the same response at in an eye. Usually when we take a patient who is not on drops, didn't undergo surgery, that's the response that we want to see. That's a good one.
Yeah, I was meaning those patients who already passed surgery and they came for us for the first time, and then we decide what to do with them, and they cannot use eye drops, and they don't want to have additional surgery. So we should choose, and sometimes we have to do, but don't like it.
No. If it's the best option, I mean, I found that there's an IOP reduction, so I will do it absolutely. Sure.
Invite the next speaker, Dr.